Okay, so we're really excited. I'm so happy to have our panelists here today. They're all experts with incredible experience in their fields. Their bios are in the platform, so you can look at them. Otherwise, we'd spend a lot of time here because they've done so many incredible things. But I want to introduce them by their names. Dr. Natalie Vader, who's here with the pink scarf. You can see her name. From the Child Mind Institute, Dr. Paul Bolton, who's at USAID, and Dr. Vivian Kidari, who's from Beyond Conflict. Thank you so much for being here. I'm actually going to be giving these three panelists the enormous challenge of answering really complicated questions in each in under 5 minutes. So I know I'm asking them to do something really difficult, but I'm really appreciative that they are willing to do this and try to condense very complex questions into quick answers. I want to start, Natalie. You know, we're thinking about what we're facing, and then we're going to talk about what we've seen working. And you provide care to children every single day, all day, and young people. We know the pandemic has exacerbated so many challenges. Children have lost family members, young people have lost friends, family members, and also time in school, right? That's led to isolation and significant education gaps. And so what does this do? What does something like this kind of context and the conflict that's going on, you know, lots of conflicts all over the world. So what does this do to kids, and what can we do about it, especially given that we're not all experts? What are you seeing right now in your practice, Natalie?
Well, I think that a lot of it depends on the degree of trauma that the child is exposed to, and also the age and where they're at from a developmental perspective. So, for example, in younger children who have lost a lot of, or who had lost, now that many of them are back in school, but had lost their kind of like their structure, their routine, we're seeing a lot of regression. We're seeing a lot of them who, let's say, they were already able to use the toilet, or they were able to do certain things, kind of like go back a little bit because they feel so much more anxious. We're seeing a lot of high rates of anxiety, and we're seeing a lot of delays just from an educational perspective, right? Like many kids, not only from an academic perspective in terms of, you know, where they're at from like a literacy level or math, but also socialization. If we think about, for example, I have a child who's 6, and she hasn't been able to play with a friend without a mask in school and like share toys or make a puzzle together in her whole school experience, right? Many of them haven't had play dates. The whole community of, you know, going to visit grandparents or going to the party, none of that had really existed for them. So just from like a baseline perspective, their life has changed so much, and what we perceive as normal for, you know, generations and generations hasn't really happened for these kids. In teenagers, we're seeing enormous amounts of anxiety, a lot of social isolation. Teenagers thrive with friends, and so much of their identity and their well-being comes from their community, and many of them just didn't have that, right? Like from not being able to go to your prom or to the big school trip or the fields, like to not being able to even see any friends for such a long period of time has been incredibly traumatic for them. And then, of course, there are kids who had an actual loss, right? Not only maybe the parents had financial issues that were very, really strict for the family. Not only did they also lose the contact with their more extended family or community, but also there is an enormous amount of kids who just lost a parent, right? And also adults who were much more overwhelmed than their baseline. So they weren't really there in the same capacity to support them emotionally and to be present, and who are many times also grieving their own losses. So it becomes, you know, it's like what you typically rely on is much more fragile right now.
Thank you so much, Natalie. I think what you mentioned at the end also is so important, right? Like the adults are also overwhelmed. So what impact does that have when you can't be the caregiver that you would normally or ideally be? Thank you so much, and thank you for being so good with the time. But I think this what you spoke about is something that we can all relate to, definitely, and obviously in conditions of poverty and adversity, it's exacerbated even more.
Sure.
So thank you, and I want to go into you know, touching on some of the things you said about just, you know, isolation and the impacts of the pandemic on children, youth, and communities in general. Vivian, what you know, I know that one of the important impacts of the pandemic is that mental health became more of a priority, and we know that this has helped reduce the stigma, so more people are talking about it. Young people are talking about it more, at least, you know, on social media. Unfortunately, not necessarily seeing each other as much as we'd like yet, but what are some of the risks also? So we wanted, I think we all want mental health to be in the front and center, but what are the risks that you've been seeing when mental health becomes trendy? Like what are some of the risks as opposed to kind of the benefits of having mental health be front and center?
Yes, absolutely. It's a very interesting dynamic because it is very positive how center stage mental health has become during the pandemic and people being more aware of the impact of things like stress and isolation. And so it's good that we're communicating about this more openly. At the same time, I do see a lot of social media posts where sharing like everything in social media, right? We digest information in very small dosages, right? So we don't get to have the nuance of an explanation. We just get like a flash message. And so I sometimes will see posts being shared like, here is where betrayal trauma would hurt you in your body. And if it hurts in your stomach, it's this type of trauma. And if it hurts here, it's this other type of trauma. And they have thousands of shares and thousands of likes, and they are not based on science. And I think people are craving explanations for their distress. People are looking for answers. This is why they share these materials. This is why they like them. But at the same time, when there is a mismatch between what one is experiencing and what these materials are saying what should be experiencing, then that does lead to more stigmatization. They're like, oh, well, it says that if I had done this, I should have felt better. I didn't feel better. Why? And so the risk is either that they will dismiss the potential of mental health services to be helpful because what they tried that they thought was a mental health service in fact was not, or that they will feel more isolated and more stigmatized because if we also lose the nuance of like how severe some mental health challenges can be. So like if we the more common it becomes for us to say like, oh, I have PTSD because this happened to me, and it isn't PTSD. We are stressed, we are affected by something negative that happened to us, but it's not clinically PTSD. But people who do experience these illnesses, they also experience them in a spectrum, and when they are severe, they are crippling. And so there's something also painful and isolating in seeing the progress of people who have either less severe or do not meet criteria, and those that are like actually struggling. I'm like, well, none of that worked for me. So I think that we just need to get on this wave of information and people seeking answers, but with accurate information that it becomes as attractive and as concise as the disinformation. It's a challenge, but it is something that we need to be doing.
Thank you, Vivian. Yeah, I've seen a lot of those things, right? And the kind of quick fixes and it is, I think it's something that we do have to be mindful about because that can also, what you said, and also what if you're just trying to fix something on your own, like you said, and you're not necessarily seeking care for something that could be more serious. So I think this is really important globally. And I want to jump to Paul, as we're talking about some of these challenges and lessons that we're seeing. The learning curve is really steep right now. And you've worked all over the world, Paul, in different geographic areas, socioeconomic, cultural, all different contexts, religious contexts. And I'm curious to hear from you. What I remember when we were on our call, you talked a lot about just lessons learned, like challenges. What are some of the main lessons learned and challenges that you've seen in thinking about access? We talked, Natalie talked to us about what she's seeing in children. Vivian's talking about access to information that isn't always accurate. And when you've worked on access on the ground, right, like community access also, what are some of the challenges that you've seen in trying to make healthcare more accessible to people in these different contexts? What's made it really tough, and also, what opportunities have you seen?
Thanks, Elena, for inviting me, being on the panel. I'm really happy to have a chance to talk. But as you said, there's a lot to talk about. So I tried to distill it into a couple of things. For me, in looking across programs that have been successful, to me, it's all about localization, understanding local situation to begin with. I mean, in terms of access, I actually think there's three related issues. There's access, there's acceptability, and there's appropriateness. And you have to address all three to get to have people really feel comfortable and able to come to services. So if we talk about access, access is going to be things like just basically physical access. What prevents people from accessing services? And these can vary by culture and gender and age and other factors. So, for example, we need to provide services at times that people can go when they're not at school or work, or they have family responsibilities. And childcare is an issue for women with children. Distance and travel costs can be an issue. In some countries, women need to have a male family member accompany them. So we have to understand what all of these barriers to actually coming to seek help actually are. I haven't talked about the online barriers because I haven't had a chance, but it's the same thing. We have to understand all these constraints in order to design accessible programs. But then I mentioned acceptability, and acceptability is whether a service is provided in a way that doesn't conflict with local culture and norms. So if we're using private counselling, we need to be careful about whether a man can counsel a woman in private or vice versa. And there's also stigma issues. Can we provide services discreetly in ways that people can, in situations where it's actually stigmatizing to seek mental health services? And then the third issue is appropriateness, whether people feel that dealing with mental health problems is actually worthwhile or even possible, and whether the approach we're doing makes sense to them. And so again, locally, we have to answer some fundamental questions. Do people understand mental health problems the way that, if I'm doing the study, the way that I do, or am I developing the program? Do we understand each other as to what are mental health problems? Do people see these as priorities? Sometimes people see mental health problem as really just not something that, looms large. Although I would say that is generally, particularly in recent years, a theoretical question. It's now rare for me to work in places where people don't see mental health as a priority. Then people might think it's a priority, but they don't think there's anything can be done. So we have to understand that, and we have to counter that. We have to understand what they currently do about the problem and what they'd like to do, because that'll inform us as to whether we can create programs that make sense. So we need to have the answers to all these questions in order to really design an appropriate mental health program. And so for me, what I found is that programs that actually start out with some kind of detailed brief qualitative study of how people perceive these problems and these questions is vital to design. And then the second part of access is just how do we actually get services out to people? If we really want to provide mental health services and we want them to be accessible, they again have to be local, which means that somebody has to be able to get these services from someone nearby. We find that if someone has to access mental health services by going a far distance, about 90% of them don't go. So how do we make them local? Part of my work in the last 20 years has been to establish that local non-professional people can learn how to provide mental health treatments quite well if it's done correctly. If they are trained using an apprenticeship model of supervised practice and not, have a classroom and then you're off on your own. If they get really, truly supervised practice, it's rare in my experience that someone who has at least a high school education cannot learn how to do these programs. So we are taking more of a primary mental health care approach to mental health by having a primary mental health care provider trying to have one accessible to as many communities as possible. In the past, that might have seemed to be a big ask, but honestly, these days, mental health is really come to the fore as just a major health issue and needs to be dealt with like physical health. And I'll stop there.
Thank you, Paul. No, and I think it's understanding that, all the things you're saying. I mean, I think the localization that you were talking about, I remember you said to us that in one of the contexts that you work in, they may describe the feeling differently, like a cloud I think you said a cloud in your stomach, right? Or was it a cloud in your, something like this, the kind of how you express it is going to be different in one context and in another. So I think that's really interesting. And also, when we have Natalie and Vivian, who are both aside from working on broad public health issues, also psychologists and more clinically, and it's understanding also that providing broader access through people who aren't trained as clinicians doesn't replace a clinician, right? So it's like, it's an access issue. It's not trying to say that one is equal to the other. It's just broadening the access. And I think that's something that's super important for us to remember, and understanding. I think all three of you, and particularly in the beginning, Natalie, talking about what's happening with patients, right? Like, I think is when we think about localization, it's not only contextually, culturally, and religious and socioeconomic, but it's also, what does that mean for that person? So I want to bring it back to Natalie and said, when we talked about the challenges, but now I want to hear about what's working. Like when we think about localization also, you mentioned when we spoke, Natalie, that if we're going to provide effective mental health care, we have to know what the patient needs, which in essence is also localization, but at the very individual level. It's meeting, what does this mean to know what patients need? What does this mean in practice? And what do we need to look out for? Like what do we need to do better in order for what we're doing to work? I'd love to hear what you think about that, Natalie.
And it's very tied to what Paul was saying. But, I think the first thing is you need to understand, when we think about children, for example, we really think about families, right? Like they work as a system, right? And so for a child to be well, the parents need to be well, and so on, right? And so if you're trying to focus on the child, for example, having a hard time falling asleep, but the family is worried about having enough food, or they need to, take care of basic needs, it's not going to work. That's something that they can prioritize, right? So to really understand, how do you help the family take care of the basics, the things, the foundation that's going to make them then be approachable and able to focus on mental health related issues? I think it's really important, right? The other piece, I think, going back to what Paul was saying, is that I think that mental health treatment has kind of evolved from a more vague, like psychoanalytical approach to something much more concrete and manualized, right? Like, so it is much easier to learn a manual on how to treat anxiety or how to treat trauma or how to treat than before, where it was more relational based and much more vague, right? Most treatment, or many treatments now have, they are supposed to be 20 weeks. This is what you start with. And they're also very skills based, right? We learn more and more that sometimes what people and kids need is to have skills to cope with their emotions, or to cope with whatever is, if it's anxiety or if it's depression. And so these are concrete strategies that you can teach a family, a child, in a very specific way. Another aspect that I think has helped is that many treatments are moving from just focusing on a diagnosis, right? Like this helps to treat depression, or this helps to treat whatever, anxiety or an anxiety disorder, to more symptom-based, right? So like there are treatments for emotional dysregulation. You can have emotional dysregulation in personality disorders, in ADHD, in anxiety, in mood disorders, right? Or there are treatments for people who are rigid, who are structured in a rigid way. You can see that in depression, you can see that in anxiety, right? And so in that sense, you don't necessarily need someone who's highly trained to make up the perfect diagnosis. You can go much more by symptom and provide the treatment that you need. Another important aspect, I think, is that especially in children and in young children, we learn more and more that the more the parents are involved in the treatment, the more successful treatments are, right? Like meeting with someone one-on-one once a week for a 5-year-old or 6-year-old or 9-year-old is not necessarily going to generalize to their family setting. But giving the parent the strategies to be almost like a therapist at home, to use this constantly, is going to be much more effective. So there are even studies where they see that the only way to achieve change is if the parents are involved, that if you only treat the children, you don't really see a lot of change, right? So to also understand, maybe the child is not able to be in treatment, but you can have a parent, you can have, an adult in their life that can help in this role. I think it's also very important.
Thank you. And I have a quick question follow up, Natalie, to that. A lot of times, if caretakers, for example, here in Latin America, caretakers often have multiple jobs, and they can't necessarily be as physically present or present in many ways because of other conditions they're facing, like you said earlier, right? If you can't meet basic needs. So a lot of times they'll say that the presence of a caring adult can be really important. What is, like, at the most basic level, if you're not a trained person, but you're around, you can be that caring adult for someone, even if they're not, your child? Like, what do you need to do if you don't know all the science, or like, you know, what's.
So I think that there are three different aspects to that question. The first is, I used to work with kids who had been removed for the families because of child abuse and neglect. And many times they go to court and the judge says, okay, in order to have your child back, you have to go to substance abuse treatment, to parenting, to anger management, and to whatever, the psychiatrist. But this mom has, like 3 different jobs, no childcare. And so they fail the treatment because they just can't comply with it, right? So, like, to be realistic about what but if you tell a mom, you need to read to your child an hour a day, like, okay, is that a possibility if you have 5 children and 3 jobs, right? That's one aspect. The other aspect is that many times, for example, here we see that if you're doing, for example, parenting groups, right? So where you bring the parents to teach them how to help, and you provide like a nanny to watch the kids in a different room while you're doing the effort. You can have like high school students volunteer, but that in itself makes parents much more able to comply than if they don't have that help, because in the end, what they care about is their child safety. They cannot leave a child alone, right? And so if they have that help, it can be much better. And then lastly, I think that from again, a lot of research from kids who have been abused, we know that if you have one adult in your life who consistently believed in you, who was there for you, a teacher, a coach, a grandparent, that in itself is an incredibly protective factor for resilience, for depression, for anxiety. So obviously, in an ideal world, it would be your parents. But if that's not a possibility, just having someone who's constant, who cheers you up, who believes in you, who provides positive feedback, who's there when you need them, can be incredibly helpful.
Thank you. And I think it just makes me think, like, we can be that, right, for other kids. So
Sure.
it's right, like we can be that even if we're not practitioners. And I know that a lot of people on this conference are interested in the topic, but haven't necessarily been trained in how to be a mental health care provider. So thank you so much, Natalie. Vivian, I want to hop back to you. Vivian, because we're working on this together, that we're working on this initiative to build the capacity of what Paul was referring to earlier, right? Like how build the capacity of mental health, like lay mental health workers, right? Or there are different terms being used for it, but training people whose profession isn't necessarily in mental health, but training them to be able to provide that kind of care. And I remember you mentioning some criteria and standards, but what do you know about I know that in Beyond Conflict, you've worked on this. What can you tell me a little bit more about this? Like how, and again, referring back to Paul earlier and also to what Natalie was just saying, can you share a little bit more about this approach in terms of expanding access and what's working, please?
Yes, absolutely. So I think that also connecting to what Natalie and Paul were saying, and how like it's not just the child, it is the parents. Like it's also not just the parents, it's the communities, right? And so I think that there has been an increased recognition that we can really transform communities when we, through psychoeducation, teach people about mental health and teach people to be aware and like have the stigma about mental health. And that, in a way, is already a protective factor, because people the same way we get the flu and we get sick, we get moments of depression, we have moments of anxiety, we may have PTSD. The incidence of mental health issues is not that rare, and they could be transitional periods, right? But what happens is that when we are over our depression, we have also lost relationships, we have also lost our jobs, because the community is not ready necessarily to respond and hold us, right? So there's an awareness now that if we, by spreading information in the community, even among people who are not symptomatic, right? Like the target isn't people who are saying that they have a mental illness. It's just like entire communities, like teaching entire communities. We are able to lessen the blow and the burden of mental illness when it is present. And already that is a positive. But then also the recognition that I think largely because of how large the refugee crisis got, the World Health Organization also took a stance of, okay, we need to move towards what is scalable. In an ideal world, everybody would have access to one-on-one therapy that was culturally grounded and that had a tailored to them treatment approach based on their history. In an ideal world, that would be true, but the realities are such that we have more people experiencing stress and trauma and being in environments that are conducive to negative mental health outcomes than we have providers. So how to get culturally relevant interventions into these areas train lay workers, train peers, right? And so to what Natalie was saying, it is true. Like there are now manualized approaches that target specific types of symptoms or things like emotion regulation that are quite like through a structured way you can and you are able to teach it. And so like the first move was like recognizing and encouraging people to develop this type of scalable interventions, gathering evidence in favor of them. And there have been a lot of studies now published about how these types of interventions are producing positive outcomes in the populations. Yeah. But then the final step is, okay, so now we're there. We all want to be training the lay mental health workers. How do you avoid doing harm? How do you maintain a certain standard so that we know that what is being done is safe for the lay mental health worker that's providing the service and for the audience that's receiving it, right? Because as you scale up, you lose that control, right? And so, and in that sense, the company had the opportunity to collaborate with this incredible initiative that the World Health Organization and UNICEF did. It's a platform called Equip, and it is free to register to. And basically what it is trying to do is to create like a standard. Like what are those basic capacities that lay mental health providers should have in order to do no harm? And so we're able to have this beginning of setting a baseline of like what could be like a global standard. Like what are things that I would be like red flags, and we need to provide some training for the lay mental health worker on avoiding things like boundaries being violated or privacy being violated, and what are things that we want to be promoting in all of the settings in which we're doing mental health. And so I think that the more that we're able to sort of understand that this is where the field is at, that we need lay providers and that they are absolutely able to meet these capacities and this and engage in these trainings, then we can have a certain standard in which we can feel that it is safe. It is safe and it is positive.
Yeah, and safety is key, right?
Yes.
No, thank you. Thank you. I think the underscoring all of this with safety is so important. And I there's a question in the chat, and I want to move into it. Thank you so much, Vivian, because I think we're all going to look up Equip. I think it's probably a really great resource for all of us to keep in mind that are working in this. And I want to go into Paul, who's also worked in this space and what Vivian was talking about with lay mental health workers. But I also want to couple that with a question that came up, Paul, in the chat, and just integrate it a little bit, right? Like, how do we work with Indigenous populations, given that they may not have the same literacy rates or the language barriers? I think, what have you seen that works, right, in terms of successful programs? You mentioned earlier the access, acceptability, and appropriateness, and how has that played out, and particularly with populations that have their own language, or with populations perhaps that are older or don't have the same literacy rates? What have you seen to be successful, and what ingredients would you recommend we include as if we're trying to deliver this kind of care at a community level?
Well, if it's particularly about Indigenous populations, but you could talk more broadly. I mean, the whole localization thing becomes essential. And you referred to an example I had given, where very often with mental health, it's a subjective topic. People use metaphors. Everyone does, and Indigenous populations will have their own metaphors. So the one you mentioned was, feeling like I have a cloud inside. That was a metaphor from a population in Rwanda. And I have struggled, and I have never figured out what that means. But the point is, it doesn't really, in some ways, it doesn't matter so much that I don't understand it, but in detail. But that's that I understand it broadly, and that when we communicate with them, we use those metaphors and terms that they use, so that we're talking about the same thing. And as I mentioned earlier, we have to think about how they think about these issues. For example, if some populations in West Africa, for example, think that many of the problems we think of as mental health problems are actually due to witchcraft. Well, if people feel it's due to witchcraft, then sitting around talking about your problems for an hour each week is not going to make sense without some detailed explanation and trying to reach some common ground. Otherwise, it just doesn't seem to make sense. So I think there has to be this real effort to meet people where they are and with their understanding. What I found in working in different regions of the world is that the basic interventions don't have to change. Cognitive behavioral therapy has worked everywhere that we have tried it, as long as we have made significant efforts to adapt it to the local situation, to use locally appropriate language, to use locally appropriate examples, to meet people where they are. They are basically. I would say that those are the main considerations. And then, sort of building on what Vivian was saying about, the providers, we have to support the providers. Too often, like mental health, not only is mental health stigmatizing, but being a mental health provider is stigmatizing. And then you're part of some clinic or program where you're the lowest person on the totem pole, right? You're the least important worker, and everyone looks down on you, and you don't have any chance of any kind of professional development. And so we have to integrate these workers into established roles in whatever systems we're talking about, health systems, social service systems, whatever. We have to provide them with the training, like I said, but then we have to maintain their supervision. We have to connect them to each other. We have networks of providers who talk to each other and support each other, because frankly, they have their own issues as well. And we have to give them the ability to progress, to develop in their careers, all the things that we want. In our own careers, we have to provide for these services too. Otherwise, I find that the systems, once the funding ends, the systems just fall apart.
Right. And also, like I think, in concluding, because we're heading into the kind of home stretch, one of the, just as a thank you so much, Paul, as a final comment also, this goes back to another question from the audience, like how can we expect caretakers, parents to, you can't pour from an empty cup, right? You can't help someone if you're not okay. So I think whether it's with care providers that are trained, like psychologists, or frontline workers who are being trained, or community health workers or volunteers, just making sure that self-care is a priority. So whether, again, for parents, if just giving other people who are taking care of others the tools to also care for themselves. So I want to thank the three of you so much. I know we could have probably done a panel or just a whole session with each of you at least. Thank you so much for bringing your experience, your perspectives. I really appreciate it. For the audience, you may be prompted after the sessions for a quick, one question on the different panels, and then you'll be redirected to the agenda. But I want to thank you three very, very much. Muchísimas gracias, de verdad, por el tiempo y por traer sus experiencias, sus perspectivas. Les agradecemos mucho. Y gracias al público también. Thank you so much. And we'll see you at the next sessions. Thank you.
Un placer, muchas gracias.
Thank you. Thank you, Natalie. Thank you, Vivian.